Okay, for this portion of Module 6 presentation, we're just going to talk about mostly urinary tract infections and the complications that occur related to a urinary tract infection that is poorly treated or not identified early, which would be like urosepsis. The purpose of the organs of the urinary system are to move the urine out of the body. So when there are disorders that disrupt that, then it can disrupt homeostasis, it can disrupt blood pressure. There's lots of different other body systems that it can disrupt. So it's important to treat these appropriately before any kind of problems occur associated with urinary tract infection complications. More than 20 million people in the United States are treated annually for urinary tract infection, so it's a very common infection. A lot of times it's hospital related. That's why, as you have seen, a movement towards putting less urinary catheters in, and if you do put them in, you don't leave them in very long. They're one of the number one reasons why people get urinary tract infections. So there's a big push to not have those in at all, if at all possible. So again, urinary tract infections are common. So it's a nurse's main concern to work towards interventions that are directed towards prevention, detection of a urinary tract infection, and management of any urologic disorders. Factors that contribute to the risk for urinary tract infection, unfortunately, is it's common among women. That is all related to the anatomy of the short ureter. Or actually the urethra, not the ureter. The ureter is what connects the bladder to the kidney. The urethra is what is the opening to the outside, and it's shorter in women, so they have more risk for getting a urinary tract infection. Age is another risk factor. Age, if you recall, from Chapter 68, all of the changes that are associated to aging with the urinary system. A lot of it is decreased bladder capacity, weakened urinary muscles, tendency to retain urine. All of those things together make people more at risk for urinary tract infection. And then it's a very common, like I said, healthcare acquired infection. This is just a list of all the contributing factors, and most of them I've already stated. Obstruction. There's a good table of all of these, and with an explanation of why they cause urinary tract infections on page 1490 in your book. Just a picture to kind of review how the flow of urine should occur. Within the kidneys, that's where the filtration occurs. The kidneys filter out the waste. It retains what it wants to keep, and then what we want to get rid of, it sends down the ureters on both sides, and the bladder is a little bit of a reservoir, and it's kind of a muscle that we have that kind of holds on to the urine until it's full. Then we get that sensation if all of our neurologic system is working well, and then the urine passes out through the urethra. That is the way that a normal functioning urinary tract should work. It should flow from the kidneys out this way. If we have any sort of a reflux in any part of this where it flows that way, it's going to be putting a patient at risk, because the urine is all waste that should be eliminated from the body and not sent back up towards the kidneys. Many different ways that we can avoid getting a urinary tract infection. A lot of this should be just review, things that you have heard before. One of the biggest things for nurses is to make sure that your patient is hydrated well. If there is a hydrated patient, it's going to keep the flow of fluids going forward and prevent urinary tract infections. And then there's that catheter. If somebody's got a catheter, we need to get it out quickly. If they have to keep it, we need to do good catheter care. And a lot of other things. I think there's a good table for you as well regarding the prevention of urinary tract infections. This can be found on page 1493. It talks about drinking lots of water, enough sleep for women. They got to avoid those bubble baths. Again, it's that anatomy The bubble baths can change the pH. It's all about the pH. pH has urine has a acidic pH that the acidity of the urine can decrease the amount of bacteria. And that's a natural thing. Now, women, as they grow older and reach menopause, their pH changes, and that is because of the loss of estrogen. So their pH actually goes down to more alkaline, and that's what puts women more at risk as well as they get older and reach menopause. A lot of different natural treatments can be used, cranberry juice, and the reason that works is because of the pH. The pH of cranberry juice can actually increase the acidity of the urine and make it more protective against the bacteria. Apple cider vinegar is also a known kind of a homeopathic treatment because, again, it's the acidity. Urinary tract infection in itself is not life-threatening if it's identified early, treated appropriately with the appropriate antibiotic. Typically, within a couple of weeks, the patient is fine. However, what happens in something called urosepsis, that is when a urinary tract infection, the bacteria that is causing that infection spreads to the bloodstream. It is common among the elderly, and here's why. An elderly patient with dementia, perhaps they're incontinent of urine as well, it's difficult to tell if they have a urinary tract infection. A lot of times if they're incontinent and they're confused, they can't tell you if they're having the symptoms of a urinary tract infection. Another thing is a lot of times their PO intake is very poor and they're dehydrated. They have several risk factors that put them at risk for getting a urinary tract infection, and then they can't tell you when they're having these symptoms. So, and it's difficult for the caregiver to determine if they're incontinent. So it's very important for the caregiver to know these things about an elderly patient and identify any signs or symptoms. Maybe their urine output is low, they haven't gone as much, or they're foul-smelling urine, or their PO intake of fluid has been very, very poor. Urine is very dark. Those things like that have to be identified by the caregiver early so that it can be treated. I used to work with a lot of elderly patients in a nursing home, and I can't tell you how many patients we sent out because they were confused, they'd have a fever, and they would come back with the diagnosis of urosepsis. So urosepsis is that poorly treated urinary tract infection that the bacteria is grown so much that it spreads to the bloodstream, and it is a life-threatening thing. This is a life-threatening situation. Sepsis causes profound vasodilation, which causes a low blood pressure. It's very difficult to treat. It has to be treated with IV antibiotics. And in an elderly patient who already has a lot of comorbidities, this could be very detrimental. High mortality rate. It's a high, long hospital stay, can lead to organ failure, septic shock, and perhaps death. So that's why it's very important to know the signs and symptoms of a urinary tract infection in an elderly patient, which would be confusion. Confusion is one of the first signs. I've worked with a lot of practitioners recently who have, as soon as somebody lets them know that one of the patients have had a recent change in level of consciousness, a recent change in their just behavior, the first thing they will do is do a UA-CNS to check to see if they have a urinary tract infection, because it's typically the first sign. And then they'll look at also like their hydration status, their eyes and nose, and that can also help them determine whether that patient has a urinary tract infection or not. Okay, we're going to go ahead and move forward and talk about pyelonephritis. Pyelonephritis is an infection in the kidney, in the renal pelvis of the kidney. This is a serious infection when the kidney gets inflamed because it can cause damage to the filtration system of the kidney. It can cause damage to the nephrons. So it can be a very serious infection. A couple of different types. Acute is an acute, of course, tissue inflammation. A lot of times this is caused by a urinary tract infection that has been untreated that maybe started in the bladder, which would be cystitis, started in the bladder and has moved its way up to the kidneys. And maybe it's because that cystitis was not treated appropriately or wasn't identified early, so now the urinary tract infection has traveled up to the kidneys. Chronic pyelonephritis is typically caused, it's also can be related to a urinary tract infection, but it's usually related to those urinary tract infections that are caused by more of an anatomic type thing rather than a bacteria. Maybe there's obstruction, maybe there's a reflux in the flow of urine, maybe the urine's going backwards instead of forwards, and that can cause a chronic pyelonephritis. So it's more of an anatomic thing, more caused by something that's chronically happening in the patient as opposed to maybe that one urinary tract infection. Typically, the symptoms of acute and chronic are somewhat similar. Usually, the acute one is going to be, of course, more acute. So it's going to be a little bit more dramatic in presentation. The difference between determining whether somebody has like a pyelonephritis or as opposed to a urinary tract infection like a cystitis or a urethritis, they're sicker. They're just downright sicker. And they're going to have a higher fever, and it's going to be like they're going to be more tachycardic, and they're going to have that flank pain. They're going to have that tender costovertebral angle. Remember in, I believe, chapter 68, we talked about that costovertebral angle is that flank area where if you press on it, they have tenderness. So, and that makes sense because if their kidney's infected, they're going to have that more flank pain. It's going to be more upper area pain and discomfort, and they're going to have a higher fever. They're going to be more sick. They are going to be that patient that comes to you with just really feeling crappy. As opposed to like urinary tract infection, they're going to be, they're going to be kind of annoyed with this kind of discomfort of this bladder infection or this ureter infection. But the patient, again, like I said, with a kidney infection is going to be way more sick and way more lethargic even, just the general feeling of illness. Nocturia is another symptom of that. And with your chronic pyelonephritis, they might not have the high fever. They're going to have somewhat less dramatic symptoms. They're going to have more hypertension just from... and that's basically because of the damage to the kidneys from the chronic kidney infection. And then they're going to start developing some symptoms of kidney dysfunction. So it could be electrolyte imbalances. It could be some sodium imbalance because all of those things are excreted in the kidneys. So the people with the chronic signs are going to have more of signs related to a kidney dysfunction. The acute people are going to have more of an infection signs and symptoms. To diagnose this, of course, you're going to do UA/CNS, just with any other urinary issue, and you're going to see leukocytes, blood, nitrates in the urine, white blood cells potentially in the urine with a pyelonephritis. X-rays, KUB, remember KUB is that X-ray. And that can show if there's some kind of, especially in chronic pyelonephritis, that can show if there's any kind of a obstruction, any kind of an anatomic deformity or issue that is causing reflux of urine that can cause the kidney infection. And then the other piece of diagnosing someone is asking them signs and symptoms. Have you, especially for acute, have you had a recent urinary tract infection? What their age, their sex, things like that is going to help you kind of diagnose this. And then the fact that they have flank pain as opposed to maybe just some discomfort over their bladder area is going to determine whether it's pyelonephritis. Okay, drug therapy and not just treating for pyelonephritis, but for urinary tract infections. Antibiotics, of course. So basically what happens is you do an urinalysis that shows you that there's nitrates, there's leukocytes, there's blood in the urine. Okay, there's a urinary tract infection. So let's send it for a culture and sensitivity. Let's look at what bacteria specifically is causing this, and then we'll treat it with the appropriate antibiotic. So, and basically what that refers to is whether it's gram-positive or gram-negative bacilli, rods, things like that, and that's how they're going to choose the antibiotic. So all of these antibiotics come with a little bit of a side effect and a little bit of teaching. So you need to look at each one of those. Penicillins are pretty safe, basically. They've always been a pretty safe drug, unless, of course, somebody's allergic to penicillins. Got to know that in order to determine if they can be treated. Typically, penicillins have to be taken with food. Usually, penicillins are one of those drugs that has to be taken like a couple times a day. With all of these antibiotics, the huge teaching factor here is that you take them as ordered and you take them until they're gone. Because what happens, and we all know what happens, they start feeling better after about 4 days of treatment. It's ordered for 7 days. They quit taking it. And then they open themselves up to this risk for super infections, and that's what causes all these MRSA and VRE and all that stuff, because now we've become resistant. So big teaching strategy is the fact that they have to take them even when they start to feel better. There's sulfa drugs out there that can be used to treat a certain type of a germ. There's a lot of people who are allergic to sulfa drugs as well, so you just need to know their allergies with those. The fluoroquinolones are very popular drugs to treat a bacterial urinary tract infection. However, they come with, of course, some side effects and some serious teaching that you need to give your patient. A big part of that is the fact that they cannot take it within 2 hours of taking an antacid. They cannot crush the drugs, and it can cause a bradycardia, especially in a elderly patient. There's a lot of side effects that can occur in a elderly patient with this, as far as their heart rhythm can cause bradycardia. So if they already have like some heart block, heart failure, could be a little bit of an issue with them. The other thing is they need to stay out of the sun if they are on a fluoroquinolone. So fluoroquinolone is a common drug. Cipro is one of those. Levaquin is another one. So got to stay out of the sun or they're going to get a nasty sunburn with that. Cephalosporins, big thing with that is it is a drug that is almost like a second generation penicillin. So the makeup of that is very similar to a penicillin. So if they're allergic to a penicillin, they could very well be allergic to a cephalosporin. The aminoglycosides are great drugs. They are very broad spectrum antibiotics. Got to look at those because they can cause, you can get toxicity from a lot of those. So they have to do troughs and peaks for those drugs. And that'd be your gentamicin. Gentamicin can also cause some hearing deficits, can cause some ringing in the ears, and some hearing loss. So you got to make sure you monitor those patients. Other miscellaneous drugs, Vanc is a big drug that is very common. It's a very broad spectrum medication, but it does, again, you have to monitor for any toxicity of that drug, especially people who have renal impairment should be monitored very closely for toxicity of vancomycin. Metronidazole is a drug that is used for mostly fungal infections. In your chapter 69, there's a pretty good table of most of these antibiotics, so make sure you look all those over. But these are very common drugs that are going to be used to treat UTIs. Antispasmodics are also drugs that could be treated, and that's because sometimes with a urinary tract infection, especially if it's a bladder infection, it can cause spasms, which is very uncomfortable. Pyridium, very common drug for spasms. I think you can go out and buy that over the counter anymore. The interesting thing about that is that it will turn your urine very orange or red, so it can scare a patient. So that's a very big teaching point for them. Okay, urolithiasis, or better known as renal stones, kidney stones. If they are kidney stones, they are known as nephrolithiasis. If they are stones that are found in the ureters, they're ureterolithiasis. So these stones are known as calculi that form, and typically, if they're just sitting there, they are not causing any problems. It's when they start to move they can really cause some issues in a patient. Okay, so what causes these stones? Why do people get these? We're not really sure. There are some people who are just genetically prone to getting them. Most of them are typically made up of calcium. Typically, a person that takes in a lot of calcium is not at risk for getting stones, but there are some people who have a genetic disposition to not metabolizing calcium well, so they form stones. So it's not the high intake of calcium. It's more of the metabolism of calcium that could cause people to be more at risk for stones. So there are some people who, no matter how much calcium they take in, they actually pull in more. They absorb more, so that gives them a high calcium level that causes them to be at risk for stones. So a diet high in calcium alone does not make a patient at risk for stones, but a patient who has high calcium intake that has that genetic predisposition to pull more out of absorb more of the calcium, they are at risk for stones. All right, so the other risk factors include poor fluid intake, urine retention. So, of course, the elderly would be more at risk for this. Immobility, so somebody who is bedridden for whatever reason. Again, maybe the elderly, maybe somebody who has had some kind of a traumatic event that's caused them to be bedridden. They're going to be more at risk. Dehydration, so again, like poor fluid intake can put somebody at risk for stones. There are some medications, diuretics, and part of that's because diuretics lead to dehydration, so it can cause somebody to have stones. So the problem that occurs, like I said, is when these stones start to move. So if you think about it, if you look back at your A&P, so when they're sitting in the kidney, if they're small stones, they really don't cause any problems. However, at times they will begin to move. When they start moving down through the ureters, which if you can imagine they're very, very thin, and there's a stone trying to move down through those, they can cause an enormous amount of pain for the patient. This pain is referred to as renal colic. It is a flank pain that can actually kind of extend towards the abdomen or the scrotum or testes on a man. But it's sort of like a flank pain, which is your mid-lower back, and it kind of can radiate around through your abdomen. And that is a common description of pain associated with kidney stones. It is extremely unbearable. There are people that have said that it's the worst pain they've ever had in their life. It can cause confusion. The pain is so intense and it can be difficult to treat. The kidney stone can cause an obstruction, which can lead to oliguria, which is a scant amount of urine that comes out, which can really lead to an event. If you think about this, the urine is meant to flow forward. If we get a stone in the ureter that blocks the flow of urine, the urine backs up to the kidney. What do you get? You get a pyelonephritis from the reflux of the urine, and you get a patient that is super, super sick. So these can be a bit life-threatening if not treated well. So treatment for this is it depends on the patient. Sometimes if they're passing it, there's not a whole lot they can do, but do pain management, and then they will begin to screen the urine. They'll filter it. So basically, they'll have the patient use like a little strainer so that they can determine whether they can catch the stone or not, and that just tells the provider that they've actually passed it, and then they can actually test the stone. They can take it into the lab and determine what it's made up of, and it might just give them a little kind of idea of what was the cause of their pain or their stone, and determine whether they can prevent this from happening again. Some tests that they can do to really kind of confirm that there's stones in there. IVP, or the IV urogram, what they're calling it these days. So that's where they push the IV into the vein, the dye into the vein of the patient, and then they can see whether there's an obstruction, if there's stones in there. If they take pictures after they've injected the dye, that's a pretty common test to determine whether somebody has stones or not. You can maybe see stones on a KUB, which is that x-ray of the kidneys, urinary, or bladders. A CT scan might be something else that they can use to determine where the stones are. So again, a big part of a nursing intervention for a patient with kidney stones is pain management. And this is going to be drugs like morphine. A lot of opioid analgesics are going to be needed because it's going to be severe pain, like I said. Sometimes an NSAID called Toradol or Ketorolac. It's a pretty potent IV NSAID that can be very effective in treating. But you got to watch it because it's an NSAID and can cause some renal impairment. So you gotta make sure if your patient has any kind of baseline renal impairment that you're not going to give Toradol. Lithotripsy is a treatment for kidney stones or ureter stones. Basically, there are shock waves that can be used with a laser in order to break down the stones into smaller fragments. There are people who potentially might have large stones sitting in their kidneys, and so they can use these shock waves to break them down. They apply 500 to 1500 shock waves in a 30 to 45 minute episode of doing this. They monitor the patient the entire time. A lot of times they give them a little bit of sedation to help them through this. And then they will strain the urine afterwards to monitor for the passage of the stones. Again, that could be a painful situation for the patient, so the nurse will have to monitor them and make sure that their pain is managed with the medications adequately. So another thing that might be utilized, it's minimally invasive, but it's the placement of a stent. So if somebody has lithotripsy, which breaks down the stones, it's going to be painful for those stones to move through the ureter. So sometimes they'll place a stent, which is a kind of a little extra little tube for them. It's a bigger tube and it's less painful for these stones to pass through. So a big thing post-procedure for putting a stent in for nursing intervention, you got to monitor to make sure that the stent doesn't get occluded or it doesn't cause infection. So just basically make sure you're doing very, very strict I&O on this patient to make sure that they're putting out urine and nothing is getting occluded. Okay, moving on to urothelial cancer. Urothelial cancer is also known as bladder cancer. This type of cancer can spread to other areas of the body. Once it kind of moves on beyond the transitional cell layer, it can be highly invasive. And that's why it's important, as with all cancers, as we said, is you gotta identify it early and treat it early before it spreads to other parts of the body, because when it spreads elsewhere is when it really, really can cause some issues. So the big take home from this whole part of the bladder cancer is they might have to remove a patient's bladder. If it is contained within the bladder, if it hasn't spread, they actually can remove a bladder, and then they're going to have to build conduits that actually direct the urine flow outside of the body, almost like a ostomy that we talked about with the GI disorders. It can be done with the urinary tract system as well. So it basically is ways that you can direct the urine flow if you have to remove someone's bladder. One thing I want to point out about bladder cancer, it has really been known to be associated with tobacco use. A lot of people don't know that. They always associate lung cancer with tobacco use, but they have found recently that like 67,000 new cases are related to tobacco use. So it's just kind of an interesting thought. Because, again, like I said, because a lot of people think it's more associated to lung cancer, but there is apparently a big association between bladder cancer and tobacco use. Bladder cancer is typically one of the big signs and symptoms is hematuria. That can lead to the diagnosis, and then that leads to a cystoscopy, which can, again, that's a scope of the bladder that can go in and look and see if there's a tumor in there, and they can actually biopsy that way. It's one of the big ways that it's diagnosed. Again, chemotherapy and radiation perhaps would be a treatment for this type of cancer. You need to look on page 1514 in your book regarding surgeries that may occur in the urinary tract infection due to a cancer. There's a lot of conduits, uterostomies that could happen sometimes. They can actually take the ureters down to the sigmoid colon, and actually then the urine would be eliminated that way. But you definitely need to look at all of those different ostomies that may be done for a bladder cancer on page 1514. And think about, it puts a patient at risk. You know, every time you have an artificial opening, ostomy, things like that, you're going to put a patient at risk for infection, of course, especially postoperatively. You're always going to monitor that site to make sure that the urine output is adequate. If there's any kind of an ostomy, you're going to look at that ostomy and make sure that there's blood flow to it. Very similar to that of the GI ostomies, but just take a look at those. An ileostomy is a big one. The ileal reservoirs is looked at in that page. So just take a look at all those and just kind of look at the nursing care post-operatively of all those. Again, it's going to be looking for infection, looking for bleeding, looking for the health of the stoma itself. This is just a slide that's identifying that there can be kidney cancer. You know, the interesting thing to look at when you have somebody with kidney cancer is that we have two kidneys, and we are able to function without one of them. And then we also have treatments that if somebody has to lose both their kidneys, we have dialysis, we have kidney transplants, we have things like that that can be a treatment for those. So it can be life-changing if somebody has to go on dialysis, if they have to lose a kidney. Again, you know, they're classified in 4 stages like the other cancers that we've learned about, and it can be life-changing for a patient to have a diagnosis of cancer. Radiation and chemotherapy are going to be pulled in as well. Surgical management of a patient with a nephrectomy, they're going to have a large incision. It's going to be, you know, the health of that incision, any bleeding, urine output, of course, would be a focused assessment of that patient with a nephrectomy. And that concludes this portion of Module 6 presentation, and we will have more of a discussion in class tomorrow regarding all of these issues.